So we are going to go through this one more time. So in 2003, which hard as it is to believe, that's been more than 10 years ago, there was a reduction in the duty hours that junior doctors were allowed to work. And since that time, the number of handoffs that take place between junior doctors has increased by about 40%. On average, a patient will have 15 handoffs from their primary resident during a 5-day hospital stay. Now, that's just handoff from the resident taking care of the patient to the residents within that specialty. Of course, a patient will also have nursing handoffs, attending handoffs, respiratory may be involved, physical therapy. So the number is magnified. For these reasons, communication during patient handoffs or handovers has become a high priority patient safety initiative, not just from the World Health Organization, but also from the Joint Commission. And since it has been 10 years since we moved from the sort of situation where junior doctors were on call all the time or every second night to working much shorter duty periods, we now have accumulated pretty much a wealth of literature that shows the problems with what we're calling discontinuity of patient care. So, for example, we know that there's been a delay in ordering critical tests because the person who's cross-covering may not be familiar with the patient, may not know what the plan is, may not know what the goal is. We also know there's been an increase in the number of complications, again, possibly related to a delay in ordering tests and a lack of information about the patient with the cross-cover resident. There's also been an increase in adverse events when patients are under the care of a cross-cover resident. Length of stay has increased, which of course means cost has increased. The number of tests has increased, again contributing to an increase in cost. And in some cases, repeating a test because the result wasn't available, somebody didn't know if it had been done, it was easier to do it again. Again, not only do these increase cost, but they may increase complications or side effects, and an increase in medication errors. So again, staying with the data, we know that communication errors will occur in 13.5% of surgical malpractice cases, and 43% occur during handoffs or during a patient transfer in and out of the ICU from one care team to another, from one facility to another. And almost 60% of residents will report that one or more patients are harmed because of a problematic handoff during that resident's last rotation. So not just during their lifetime or during their training period, but 60% of residents saw a patient harmed during their last rotation because of a problem with the handoff. So what sort of communication failures can occur during handoffs? And this is from work that has been done by Vineet Arora, and if you want any of these papers, we can make them available to you. But basically what Dr. I did was meet with a group of internal medicine residents, ask them about problems that occurred during the previous rotation or the previous night on call. So it was a focus group, and she found 22 incidents where content was omitted. So either the active problem was not handed from one resident to another, it was not clear what medication the patient was on, it wasn't clear what tests had been ordered, what tests had to be ordered, it wasn't clear what follow-up was required on tests that had been done during that day. And then there were 8 incidents of communication failure. So this is a breakdown of 25 incidents from 26 residents. Communication failure included having a hurried handoff where there was no time for questions to clarify what was needed or to get additional information. If the handoff was written, sometimes the writing was illegible, and sometimes the orders were just unclear, such as get x-ray, without being specific as to what exactly was needed. Okay, so now we're just going to go to a short video. I hope.
Oh my God, that family meeting went longer than I thought. Ugh, and I have dinner plans. I have got to get out of here. Okay, I just need to update my sign out with this one last piece. Okay, let's try to print this. Oh my God, why is the printer out of paper? Why am I the only one that ever replaces this? I mean, they want us to sign out, but they make it so hard. You know, like, well, this is crazy. I'm just gonna have to use yesterday's sign out. Okay, oh my God, my pager's going off again. Where's Jeannie? I gotta go find her.
Come in.
Hey, Jeannie.
Hey, Vinny. Hey,
how
what's up?
are you?
Pretty good. Hey, can you time me real fast?
Oh, okay, sure. You know what? I gotta get out of here. I'm
Okay.
in kind of a rush.
All right. Can you get my hair behind my ears?
You know what?
Can
Oh,
you
there's
seriously
you know what?
just
There's
put it behind my
15 patients.
Okay.
And you know there's Mrs. H and oh my God, she's really sick
Okay.
and she has
Can you get my
diabetes and
can you get my
hypertension.
pager off my
and
belt?
she's oh
Can you get
gosh.
my pager?
You know what, Jeannie? I'm sorry. I really have got to run. I'm super late for this dinner.
All right.
But
Is there
I
anything? Wait. Is there anything I need to know?
No, it's all listed right there.
Okay.
You're gonna be great. Okay. Have a
Okay.
great night.
Okay, sign it over because I don't have time. Thank you.
Bye.
Hey, this is Jeannie Farnham returning the page. Yeah. Which pager? Mrs. H. Hang on a second. Mrs. H. Hang on. Yeah. Hang on a second. Mrs. H. Okay. Wait. Which pager again? I'm sorry. Okay. What's going on? Okay. She doesn't look right? Okay. What does that mean? Okay, you know what? I'm sorry, you know what? Okay, I will, you know what? Can you just get a blood gas and a chest x-ray and I'll be up there as soon as I can. Okay, thanks. Oh, are you the nurse for Mrs. H who paged me?
Yeah, I just picked her up. I don't really know much about her. All I know is that she's got a really difficult family.
She looks terrible. Can you forebell anesthesia? I'm going to go call the ICU team. I think she's going to need to go to the ICU.
Okay, all right.
Hey, Jeannie. How are you?
What time is it?
Oh, you know, it's like 7. You know, I hope you had a good night. Did you know, like I hope you weren't too busy or anything.
It wasn't too bad. Mrs. H coded and went to the unit though.
Oh my God, Mrs. H.
Yeah.
We made her a DNI. Like her family came in. It was like super complicated. I mean, what are you talking about? Like.
It says full code on the sign up.
Oh my God. I must have forgotten to update it. I am going to get in so much trouble.
Okay, so comments on that as a handoff? Is that how it happens on your service? Any comments? What was wrong with it? Obviously, it was not a good handoff, right? Are we all agreed it was not a good handoff? This is the interactive part of the talk now. Okay, we're all agreed it was not good. What was wrong with it? Well, it was non-existent. I wouldn't say it was non-existent because there was an attempt. There was an attempt to communicate. But specifically, what should have been done? What could have been done better? Come on, guys. You know this. Help me out here. Okay. Okay, so I'm not sure how much of that you're able to hear, but we're going to go through it all again. So there are different ways to communicate, and we're going to talk a little bit about content and process on the next slide. But what I had on this slide were just 2 ways to communicate information very quickly about a patient. I'm sure you're all familiar with SBAR, which is a formula that was developed by submarine commanders to develop in order to communicate more quickly and more efficiently with the commander of the submarine. And basically where you say, this is the situation, here's the background information, give an assessment, a recommendation, and I've added in repeat because it's one of the problems with SBAR is that it's a sort of a one-way communication. It's basically saying, this is what's going on, but there isn't that opportunity to be interactive. The formula that I prefer comes from Wyke, and this is based on research that's been done with forest firefighters by Carl Wyke, who's written quite a lot about organizational development. And the formula is somewhat similar, but basically what's different about this is that not just that they're saying, this is what I think we have, here's what we need to do, but it says why. And helping, when you're giving a handoff to somebody, explaining why something needs to be done, really helps clarify for that information for them. And I'm going to come back to that again when I talk about communication. It also explains this is the plan, this is what we need to keep an eye on. But that all-important part at the end, tell me if you don't understand, can't do it, haven't done this before, what am I missing here? That opportunity, which I think you alluded to, which was the opportunity for questions to verify what has been said and to confirm that everybody's on the same page. So 2 ways of communication. And then what about process? Again, we highlighted all of these in our discussion. Handoffs should take place as far as possible at the same time and in the same place every day. Now, sometimes emergencies will mean it just has to be done over the phone, but it's not ideal. It should be face-to-face in an ideal world. It needs to be interactive, so there needs to be the opportunity to ask questions to confirm that what I'm saying to you, or what I think I'm saying to you, is what you're hearing from me. And again, I'm going to come back to that in a moment. And then try to minimize interruptions. Often your handoffs are taking place at a time when the nurses are also changing, other programs are changing, and people are calling you and saying, hey, just before you go, can you do this or whatever. Try to minimize interruptions. Not always possible, but try to assign one person to take the pages while everyone else is doing the handoffs. Now, the content of the handoff, I've given you a couple of formulas, but the specific content is going to vary by discipline. There may be one thing that's important on internal medicine or psychiatry. It's much more important than on a procedural specialty. As a minimum, you need to identify the patient name, their location, what's their baseline exam. Now, the baseline, if you're signing out patients, particularly from ICU or from an intermediate care unit, it's helpful to bring the person you're signing out to the bedside so that everyone understands what's meant by a baseline examination. You know, you can say to the person who's coming in, so-and-so's stable, but they don't know what that means. And maybe they've had blood pressure, you know, in the 40s overnight. They've been tachycardic. You've been resuscitating them all night. Now the blood pressure's up to 90. Okay. But having somebody come at the bedside, letting them get a view of what the patient looks like, will really help the incoming resident when they're called an hour later to see that patient, because then it will be easier to pick up on a change. So something that's really important, if you can't do this with every single patient, but with the patients who are critically ill, who are most important, try doing a sign out at the bedside so that everyone is on the same page. Make sure that in the handoff you include the problems to look out for, what needs to be done. Get the chest x-ray, call the chief resident. If the hemoglobin is this, they need to be transfused. When you need to call the attending. What tests are pending and who to call. Okay, so we're going to move on a little bit now from handoffs to talk about communication in a broader sense beyond handoffs, but there will again be some common themes here. Again, I alluded to this paper already from Chris Greenberg, which looked at 60 surgical malpractice claims that involved communication breakdown and patient injury. And in this study, they found that there was only one communication error. So it wasn't a whole cascade of events. You're familiar with that whole Swiss cheese effect, but this was not what was happening. In 72%, there was just one breakdown in communication that resulted in injury to the patient. And most of these were verbal communications. 74% involved what we call status asymmetry. And status asymmetry simply means that the handoff took place between individuals of either different levels of training, between different disciplines, different professions. So everybody comes to the workplace with a different expectation, comes from a different training environment, different things mean different things to you. You may have picked up from my accent that I didn't train here. And when I came to the United States, even coming from an English-speaking country, I had to learn a whole new vocabulary. There were words that we used in our training that had a totally different meaning here. So remember that. People bring different cultural norms to the workplace, and ambiguity about responsibilities as well. And how often when you're on rounds with your team, do you throw out an order, let's get a chest CT, or whatever that order might be. It is so much more effective to say, Mary, you need to do this. Or identify the nurse, identify the team member who's going to follow up on the order, instead of just throwing out orders to the room or to the team, because then everyone assumes somebody else is taking care of it. Common breakdown problems involved residents failing to call the attending about critical events. And this is one study from the Harvard group where all incoming residents were given a list of situations or conditions or events in which it was mandatory to contact the attending. And in this particular study, the attending was in hospital on call at night. So the attending had to be informed of admissions, unplanned events, any cardiac arrest. This was a surgical service, major wound complications, new blood transfusions, etc. A pretty standard list of events that might mandate a call to somebody higher up in the hierarchy. So then they went back after 3 months and they identified 80 of these critical events that had taken place during the study period. And they found that in a third of cases, there was no attempt made to contact the attending, even though all the residents knew this was mandated. And the residents felt, well, it wasn't going to change management if the attending knew. But in fact, when the attending was contacted, management did change. The attendings all said they were quite receptive, all said they were happy to be contacted. None of the attendings were abusive when they were called at night, and they certainly all knew the patients when they were called. So why is there this reluctance to ask for help? Well, again, moving back to some studies from Vinita Arora and Jeannie Farnan, they again met with a group of internal medicine residents, and having identified 18 critical events that took place in the previous 24 hours, tried to drill down reasons, first of all, why there was a critical event, and then who did the resident go to for help. So the critical events included a lack of clarity about how to do a procedure. So somebody was told to put in a central line, never done it before, or they weren't clear what was the right decision to make, or they weren't clear what was the goal for the patient. You saw that in the video. The patient was DNR, and the resident perhaps didn't know this. In this same study, when residents had difficulty, weren't sure what to do, even though, again, the attending was in-house and they were told they should contact the attending, the tendency was to go to a colleague, even if the colleague was from a different specialty. So internal medicine might be more likely to ask their psychiatry colleague, what would you do, rather than go up through the chain of command. Or they would go to the literature, or ask a senior resident or a fellow, and then lastly to an attending. Now, there's nothing wrong with asking your colleagues or going to the literature. This is all commendable. The point of the study was that these residents were told you need to inform the attending, but there was a reluctance. So why do we have this reluctance? Well, we have a culture, unfortunately, that impedes speaking up or asking for help. And this may be true in some specialties more so than in others. Residents are afraid to speak up because they're afraid they look dumb, afraid it will be reflected in their letter of recommendation, afraid the attending might think, well, don't they know how to manage this themselves? Will somebody shout at them? But as attendings, we also have to take responsibility. And if you're a senior resident, you need also to pay attention to this. We have a tendency to praise independence. So how often have you heard maybe your attendings or your chief residents say, oh yeah, I really like it when so-and-so's on call. They never call me. They manage a busy service all on their own. So we need to be careful that we're not sending mixed messages. On the one hand saying, yes, I want to be called. On the other hand saying, oh, it's wonderful that they don't call us. More and more now, we're starting to talk about the tension between supervising residents and for you, supervising your junior residents or medical students versus giving the autonomy that is necessary to learn how to practice independently. And more, this has become a topic of conversation. Certainly within my field of surgery, we now have a situation where 90% of residents who come out of general surgery training feel that they're not quite ready to practice independently, because for lots of good reasons, it is much more difficult for us to give you the autonomy that you need to practice independently in residency. So the other barrier has to do with the hierarchy. Interns may be reluctant to go straight to the attending because they feel they should talk to the more senior resident, who should talk to the chief resident, who should maybe go to the fellow. So even when a patient is an extremist, there may be a feeling that you've got to respect the chain of command. And this is certainly the old teaching. Don't, that you had to work up the chain rather than going straight to the attending. So one of the things that makes life difficult is that right now rotations are shorter, so you may take you a little while longer to get to know the residents you're supervising or the medical students that you're on your service. And there are several different models for supervision. And as I work through these, you're probably going to think, oh yes, that's Dr. So-and-so, or that's such and such a person. So routine supervision is where somebody always double checks on what the resident is doing. Responsive is the person who responds depending on the level of training of the resident, the patient situation, the difficulty of the case, what they know about the resident, and their previous experience. Direct care is where the supervisor makes all the decisions, manages all the care. And then there's backstage where somebody is constantly just double checking, going to the nurses saying, how's so-and-so doing, or going to the chief saying, how's this resident doing? So there may be a place for all of these models of supervision. Where we have difficulty is if you only use one model. So you've probably worked with people who micromanage every single decision that needs to be made on your service, even as you become more senior, and you know how frustrating that can be. And equally, it's frustrating when you feel that somebody is not around and can't be asked for help. So as you move into supervisory roles, think about how you supervise and how you make those decisions. And this is a study from Tara Kennedy, who, and the previous work was also from one of her studies. And what she did was evaluate how do we trust somebody? What are the dimensions of trustworthiness? What impact whether or not we feel we can trust a junior? Any thoughts on what might be important here? How do you decide if you can trust somebody? Is it something you've thought about? Well, there may be an assumption that they've been through medical school, their first year, their second year, their third year. I can trust them. But I think we all know that in practice, there are people with whom we work. When they're on call, we know they would take care of the patients at night and will call us if there's a problem. So what Tara Kennedy identified as the dimensions of trustworthiness, there were four constructs. Knowledge, whether or not that resident knew their limitations, were they conscientious, and were they truthful? So what do you think might be the least important of those four? Knowledge, exactly. Knowledge was the least important. And whether or not somebody was truthful or conscientious was the most important. Certainly for me, what always makes me feel I can trust somebody is if they come to me and admit to a mistake before I find out about it. Somebody that will actually own up to an error will really impress me. Okay, so I'm just going to tell you a story as we transition into a couple of tools. So this is a story of a fire that took place in 1995. The commander sent a team of firefighters into a burning building. And because the building was on the side of a hill, he thought he was sending them in on the first floor of a one-story building. But in fact, they went in on the second floor and the fire was underneath them. And the building collapsed, became engulfed in flames, and there were 4 firefighters who were killed in that event. But there was one rookie firefighter who made it out alive, and he told a story of how while he was fighting the fire, his helmet fell off. And he bent down to pick it up, and he noticed that the floor was really, really hot. And at the time, he just thought, well, wonder why that's like that. He was new, didn't want to ask a dumb question, and just said, well, I'll find out about it later. So the point is that as we often see things that don't make sense to us, and we need to have an environment in which it is safe to say, this doesn't make sense. Why is this going on? And I can remember a story many, many years ago when I was a medical student going to assist a senior resident who was doing an appendectomy. And as the patient was asleep, I noticed the lower part of his abdomen was particularly distended. And I sort of thought, wonder why that is. Now, in fact, as the resident opened to do the appendectomy, he went straight into the bladder because this child who had Down syndrome had urinary retention, and that was the cause of the abdominal pain. But at the time, I just didn't want to appear stupid, so I didn't ask a stupid question. So the lesson here is when you see something that's not making sense, question it. It may save a life. Okay, so what we're actually talking about here is what we call situation monitoring. And this is perhaps a clumsy term for just looking around you and seeing what else is going on and what might impact the safety of the patient or the well-being of your team. And there is a mnemonic which is called STEP, S-T-E-P, which is worth thinking about as you pay attention to situation monitoring. So status of the patient may be obvious, but it includes if you're in the, if, for example, you're in the operating room or you're focused on a procedure, looking around to see what's going on in the monitor, or you're in the ICU, you're in the critical care unit, you're focused on putting in a central line, watching the monitor. What else is happening with that patient? Look at your team members. Have they all got blank faces as you talk to them what needs to be done? Do they look exhausted? Environment means checking whether or not essential equipment is available. You're down in the emergency room. Have you got an ICU bed? Can you get into the X-ray department? Do you need fluoroscopy? And then the plan. What's the next step? How do we get there? What do we need to get there? What have we done so far? So being an effective supervisor and communicating with your team means creating an environment in which people are comfortable saying, I don't know how to do that, or I've made a mistake, or are comfortable getting constructive feedback. And we're not going to spend a lot of time, we're not going to spend time at all on feedback. That will be part of another discussion. But basically, mutual support just means watching each other's back. Looking around you, look at your team members. Are they struggling? Is one team member carrying a higher load than the other? Make sure you distribute the work equally. We all have this tendency to ask the diligent, conscientious person to do more and more work and spend less time with the resident that we know will need more coaching. So we almost have an upside-down reward system whereby we reward a hard-working person by giving them more responsibility. We all do this. Think about it. Make sure that you're being responsible and coaching those members who need coaching versus just dumping on people that you know will do the job efficiently. I'm sure you're all familiar with the brief, and this only takes a few seconds at the beginning of the day or the beginning of an outpatient session, a clinic session, just to talk about who's on the team, who's going to do what. And you can use a checklist such as the one that you see on this slide. Establishing roles, establishing expectations, what do we expect is going to happen, what might go wrong. Did somebody not show up for work? Does somebody need to take on extra responsibility? And similarly, at the end of the day, there's a debrief, which is simply going through pretty much the same list. What do we accomplish today? What still needs to be accomplished? What were the problems? What can we do better the next time? Did we make any mistakes? How can we avoid happening that the last time? And the check back, we alluded to this during the handoff when we talked about the importance of communication being interactive. So the check back is basically where I ask you to do something, you repeat it to me, and I confirm that you have heard what I asked you to do. And then the call out is something that takes place during a code where somebody is calling out the vitals, calling out orders. But again, remember, when you're calling out orders in an emergency situation, identify your team members ahead of time, if at all possible, and it is not always possible in this emergency situation. But not only do you want to call out the orders, but identify the person who is responsible for doing that order or carrying out the task. Okay, and this is just one other formula for communication. So this is based on some work that was done here by Reed Williams and others, where they talk about the smart step back. So this is something that you can do during an emergency situation where you just need to take 30 seconds to just take a step back and say, okay, what's going on here? What do we need to do? How quickly do we need to do it? What can go wrong? And again, what have I missed? What questions do you have? And this is a useful tool to use in the emergency room or during a code. So we're going to go to one other video. And this is
Cactus 15.9, new departure to contact line, maintain 15000.
Maintain 15000, Cactus 1549.
Cactus 15.9, turn left lane 270.
This is Cactus 1539, hit birds, lost thrust on both engines, returning back towards LaGuardia.
Okay, you need to return to LaGuardia. Turn left heading up 220.
220.
Tower, stop your departures, got emergency returning. It's 1529. He bird strike. He lost all engine. He lost the thrust in the engines. He's returning immediately.
Cactus 1529. Which engines?
He lost thrust in both engines. He said.
Got it.
Cactus 1529. We can get it for you. Do you want to try to land runway 13?
We're unable. We may end up in the Hudson.
All right, Cactus 15.9. It's going to be left traffic to runway 31.
Unable.
Okay, what do you need to land? Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire. Actually, LaGuardia departure guy, emergency inbound.
Hey, go ahead.
Cactus 1529 over the George Washington Bridge. Wants to go to the airport right now.
Wants to go to our airport. Check. Does he need assistance?
Yes, it was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 1529, turn right 280. You can land runway 1 at Teterboro.
We can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the Hudson.
I'm sorry, say again, Cactus? Cactus 1549, radar contact is lost. You also got Newark Airport up at 2 o'clock in about 7 miles. Eagle 54718, turn left thing 210.
210, 4718. I think he said he was going in the Hudson.
Cactus 1529.
Okay, and he did go in the Hudson. So you're all familiar, you've probably seen, I'm quite sure you've seen that before. So what you saw on that videotape was a computerized reconstruction of the video, but the voices were the real voices of the real-time recording of the communications that took place with the captain and with air traffic control. So how long do you think it was between the birds striking the engine and the plane landing in the Hudson? Well, it was 90 seconds. How often did the plan change during that 90 seconds? 3 times? I'm hearing 3 times? It changed 3 times. And I'm showing that video just to illustrate that clearly this was an emergency event, but it's not necessary to shout and scream. You can remain calm even in a life-threatening situation. Now, the air traffic controller seemed a little confused, and he may need a little bit of work, but certainly the captain who was in charge of the situation was able to remain calm, and disaster was avoided. So even when a patient is coding, try to take a deep breath and try to communicate calmly. So just before I hand over to Debbie, just to remind you that we now have a wealth of data that shows the impact, the good impact and the good outcomes that can result from team training. These include less errors in the emergency department after the debrief was introduced. Similarly, in the ICU, the length of stay has been shown to decrease in one other study. And this was a decrease in sepsis when people did a timeout and a brief debrief in the operating room, and similarly, a decrease in adverse events in the emergency, in the labor and delivery ward. So just as sort of a segue into Debbie Santini's talk, I'm going to leave you with that quote from Theodore Roosevelt. People don't know how much you know until they know how much you care.
I'm Debbie Santini. Thank you, Dr. Sanfi. I work in residency affairs here at the school. As we've seen in the series of presentations that have been conducted over the last couple of years in these patient safety and quality improvement sessions, there are tons of opportunities to improve patient safety, quality improvement, communication, handoffs in all areas of the hospital. But I'm a huge believer that there are also countless opportunities to improve those very things in the clinic setting too, most often even before the patient gets into the clinic to see you. I'm speaking to you today as a patient, not as the person that has to hassle you all the time to get your duty hours done, but as a patient to make you a little more aware of what patients encounter regularly in the healthcare system on the front end, what I call the front end of the healthcare system. I have 3 cases out of literally thousands that I have that I want to tell you about today. And as I'm telling you about them, I want you to think about the things that your patients experience when they come to your clinic and whether any of these things could have happened to them. I'm not a professional speaker or a medical person at all, so please bear with me as I read my notes so I don't omit any important details. So our first case, if I can find the key here, there we go, is on a sunny spring day, this man is working in his yard when he snags his hand on a tree branch and gets a tiny little cut. A few days later, it's apparent that it's infected, so he tries to get in with his doctor, but is told there are no openings, and they send him to an urgent care clinic, which is perfectly acceptable. So he goes there and he gets some antibiotics, but the infection doesn't clear up. So 2 more times over the next 6 weeks, his hand gets worse and worse, and he keeps calling his doctor, and they say, sorry, no openings, go back to urgent care. So he goes back to urgent care and then sees a different doctor, and they give him antibiotics again. And he continues to feel worse and worse until one Sunday in early summer, he collapses at home, unable to move from the waist down. So the ambulance takes him to the hospital, where they determine that this infection is now system-wide and it's in his spine. So he spends several months in the hospital with infectious disease specialists and IV antibiotics, and then 8 weeks of inpatient rehabilitation right over here at Memorial, trying to get some mobility back. He was discharged from the hospital in early to mid-November, and is told to follow up with his doctor in clinic 2 weeks later. So him and his wife for the next 6 weeks call the doctor's office every couple of days and try to get an appointment, but they're told there are no openings and the nurse will have to call him back to work him in. So they get more and more frantic and call, and no one ever calls them back. Until mid-December, the nurse finally calls and lets them know that the pharmacy had called to get his prescriptions refilled, but the doctor was declining to do so because the patient had failed to follow up after discharge from the hospital as instructed. So the patient and his wife are frantic and very upset, and they explain that they've called at least a dozen times for an appointment and no one's ever bothered to call him back. They also tell the nurse that the extended 5-month time away from work for this recovery has hit their finances very hard, so they definitely need the appointment to take place before January 1st, when all of their deductibles start over. But the nurse tells them that that can't be because the doctor's schedule is completely full. And so in mid-January, they finally get in to see the doctor for the follow-up that was supposed to happen 2 months before that. So I hope these are sort of rhetorical questions for you. Could anything like what this patient experienced happen with any of your clinics right now, in the past, in the future? This patient was very, very, very sick, but despite his horrible infection and all the opportunities for problems and medical errors in the hospital, he survived a 5-month stay, only to be lost in the system, which is what his doctor told him happened when he was finally able to get in to see him in the middle of January. He's fairly certain that had the hospital not called, or that the pharmacy had not called the doctor, he'd still be waiting for a call back and would not have seen his doctor yet at this point. The second case is a healthy female who developed trouble swallowing, was referred to a gastroenterologist, and had an EGD done. After the procedure in the recovery room, the doctor tells the patient and her family that they didn't see anything too questionable, but they dilated the esophagus and biopsied multiple areas. The doctor promised a call with the biopsy results within the week, but that didn't happen. After several weeks of calling the office and then sitting anxiously by the phone, waiting for a call back, which is what we patients do, someone finally called and told the patient that all was well with the biopsies and that the doctor recommended repeating the EGD in 5 years. So the patient went on with life and was relieved, and other than being aggravated at the lack of communication, went on with her everyday world. Then a year later, the patient received a letter from the GI doctor's office reminding her that based on the results of last year's procedure, she needs to schedule another EGD to have the biopsies repeated. So the patient is quite confused and alarmed. She called the GI doctor's office and was told the nurse would call her. But again, the patient hung up the phone and started the cycle of waiting anxiously for a call back, making sure her phone's charged, keeping it close by at all times, checking it to make sure she didn't miss a call, and that it's still working. But the same scenario as before. No call, call again in a few days, try not to express anger because then you'll be labeled and we'll never get a call. But again, no one called. After 3 weeks of this, the patient searched for and found an email address for the doctor and sent an email explaining about the verbal report and the letter and asking what you have to do to get a call back from anybody there. The doctor responded promptly to the email saying patients are not supposed to email the doctors. They are supposed to go through proper communication channels. However, the doctor did promise to try to figure out whether the verbal report from last year was correct or if the letter from this year was correct. So more rhetorical questions. But the last question is one that I would like your answer to. What do you think? Should this patient feel confident that the latest communication is accurate, that all is well with those biopsies and she doesn't need to repeat this in a year? Who says that she should feel confident? Anybody think she shouldn't be confident that everything's okay? Anybody think anything at all? Okay. What would you do if that was you? Would you accept that and just go on with your merry, happy life? Okay. So our third case is a 57-year-old man. A few years ago, he developed a neck pain that rapidly worsened over a few weeks. He thought the unbalanced weight of carrying various weapons for over 3 decades in the military had caught up with him. Plus, he thought maybe the extra weight of the heavy bulletproof vests they recently added to his Air Force uniform could be causing the pain. But it didn't get better, and in fact, it got much worse, and his hands started to shake all the time, which made it difficult and probably unsafe for him to handle the required weapons at the air base. So in mid-November, he called for an appointment with his doctor. He's told there are no openings for 8 weeks, but he can see a PA in 3 weeks. So he took that appointment. We'll call this day 1, even though he has had the pain for a few weeks at this point. This is his first attempt at entering the healthcare system for this problem. So on day 21, he sees the PA who orders a neck x-ray, prescribes ibuprofen, and tells him to return for follow-up in 4 weeks. On the way out, he stops to schedule his follow-up appointment and finds out that he can schedule with his doctor in 5 weeks, so he schedules that instead. The x-ray was done at the local hospital the day of the first appointment, day 21, but after a week, no one had called the patient back with any results. So the patient called the office and was told someone would get back to him. On day 30, someone finally called and told the patient that the x-ray showed arthritis and said, we're going to get you set up with some PT. We'll call you back with that appointment. So it took 9 days to get x-ray results to the patient. How soon can you get x-ray results, and how soon do you get them to your patients? Or test results, any test results, I guess. Anybody? Pardon me? Few hours, thank you. Okay. My brother-in-law's a radiologist, and he tells me the x-ray results are typically available the same day, if not early the next day. So is it acceptable for a patient to have to wait 9 days to get any x-ray results? I don't know. As a patient, I don't feel that's acceptable. And about that physical therapy, no one called to tell the patient when or where to go for PT, and no one ever returned his calls asking about it. So day 56, the patient returned for his follow-up appointment with his primary care physician, and he's in so much pain that he can be upright for maybe 20 or 30 seconds at a time. He takes his giant ibuprofen pills religiously, but he's not really getting any relief. He's been unable to work for 3 weeks at this point. And when he gets into the doctor's office, he has to lay on the floor for 45 minutes waiting for the doctor's office to call him back for his appointment just because he can't be upright. So at this appointment, his doctor reads the radiology report for the first time. Now remember, the x-ray was done on day 21 and this is day 56, so this report is now 35 days old. The report contains no mention of arthritis at all, but instead it says there is a distinct step-off at C2 and C3 of unknown etiology, and further imaging is essential. There's no explanation from the doctor as to why the patient was told it was arthritis, but the x-ray doesn't, or the report doesn't say that. So there's a lot of confusion. The doctor prescribes a strong muscle relaxer and then tells the patient to continue PT and return in 2 weeks. But the patient says, what the heck? Nobody ever bothered to let me know about physical therapy and nobody ever called me back to let me know when to go or where to go. So the doctor looks back through the medical record and then apologizes and says that PT was, a note was written for it, but it was never ordered. So he gets that done. And then the patient's wife says, hold on, the radiology report says more imaging is needed. Can't we get that done? And the doctor says, no, we haven't tried conservative measures long enough. We need to hold off and give this physical therapy a try and see what happens. So the patient and his wife leave. And on day 69, the patient returns to see the physician for his second or third appointment, but only the second appointment with the physician. He had had no improvement at all. In fact, he was worse, even after 3 physical therapy sessions. The doctor tries to console him and tell him that PT takes a while to help and tells him to continue with the physical therapy, increases his medication, and to return in 2 more weeks. But the patient and his wife stand in front of the door and refuse to leave until an MRI is ordered, or a scan is ordered, and that finally gets done. That takes place on day 73. And as soon as the images started coming across, everyone in the building practically jumped to attention because the picture showed that C3 was completely shattered by a 5-centimeter mass that was also displacing the spinal cord. The radiologist comes in to tell the patient and his wife about the mass and informs them the patient's neck is critically unstable. The radiologist and the patient's physician confer on the phone and agree the patient must be admitted. So he is very carefully transported down the hall to the MRI suite, or from the MRI suite down the hall to the ED, and told that he's going to be admitted to stabilize his C-spine and for comprehensive scanning and testing. After a cursory neurological exam conducted by a dismissive ER physician, the patient spent 6 hours laying on a stretcher in the hall in the ED with no consults, no treatment, no pain relief, and no admission orders. And finally, a nurse comes in and tells him, you know what, it's Friday night now. You know, there's really nothing that's going to happen over the weekend, so you'll be better off at home. And they send him home with this white thing to Velcro around his neck and instructions to see a neurosurgeon the next week. And he's told, you know, you really need to be sure not to stumble or bump your head, as that could be fatal or it would have serious, dire consequences. So day 77, he sees the neurosurgeon who orders a CT-guided needle biopsy, which is done the next day. And he waits after a week and hasn't had any results from the neurosurgeon's office. So he calls and they say they don't have anything yet. So they hang up and he waits. And finally, on day 92, the nurse calls and says the results show sarcoma, non-metastatic, and that the mass in the neck is considered to be the primary tumor. The nurse said she didn't know what the next steps in the plan were, so somebody would have to call back about that. On day 93, the patient received a copy of the official written biopsy report, and it says this: metastatic high-grade sarcomatoid carcinoma. So totally different than what they were told on the phone, when that changed everything, of course. The biopsy report suggested that the primary site could be anywhere in the body, and said that further imaging needed to be done to try to identify the primary source so treatment options could be determined. When the neurosurgeon finally called back, he said that he had no explanation for the extreme differences in the verbal report and the written report. And he tells the patient that there's nothing he can do for him, that his situation is not operable. But he's referring him for another opinion with another surgeon, and that they've scheduled that appointment for him for 3 weeks later. 3 weeks. It's already day 93, and somehow they think it's okay to wait 21 more days. So the patient's wife goes a little bit crazy and gets the appointment moved up to just 8 days later. On day 101, the patient sees the second surgeon, who concurs. He says he can't do anything for the patient, but he suggests that maybe a gamma knife could hold some hope. He promises that someone in his office will call with that consult set up, but as of this very minute today, that's never happened. So here the patient is at day 101, 28 days after the mass was found, and his neck was determined to be critically unstable. A biopsy has been done, but no other tests or scans or anything has been done to try to find the primary location of what they're saying is a very strange, very aggressive tumor. 2 surgeons have said, I can't help you, and sent the patient on his way. So unable to get anyone to call them back, the patient's wife sent an email to the patient's primary care doctor pleading for him to order the scans and tests and for the patient to be sent to an oncologist. She also ended up having to contact the radiologist who found the tumor initially, and he helped the patient by paging the primary care doctor on the patient's behalf and getting things moving. Those very essential scans were finally completed over the next 10 days. So on day 113, the patient gets to see the oncologist finally. He reviewed the scans with the patient and his wife and children, and he tells this patient that his situation is actually very grim and recommends making sure his affairs are in order. A second opinion 2 weeks later concurs. And the patient and his wife were actually very shocked to be able to get into a major cancer center 100 miles away within just 2 weeks, when it took 4 months to get anything done here. And not just 4 months, but multiple instances of misinformation and countless unreturned phone calls. The patient is clearly unable to work and hasn't been unable to since mid-December. But he has several months' worth of sick and vacation time that he would prefer to use instead of going on disability benefits, because he desperately needs to keep his insurance, his health insurance, in force without having to pay for COBRA on the drastically reduced benefits that disability brings. In order to do this, his employer requires that a form be signed by the oncologist saying that his health situation will prevent him from working for at least 6 months. The patient's wife hand-delivered the form and a pre-addressed, pre-stamped envelope to the oncologist's office, where they promised to get it signed and mailed back to the patient's employer that same day. But 6 weeks later, the patient received a termination notice from the airbase because he had failed to return to work, and the required form, which would have excused him, was never submitted. The form was, in fact, still sitting on the desk of one of the oncologist's employees. And The very rare, very weird, very aggressive cancer took this patient's life not long after he received that termination notice. So I'd like to tell you that situations like this are extreme, rare examples. But in talking with people around the country, it seems to be somewhat typical. And if you just do a simple Google that says, "my doctor won't call me back," you'll be swamped with all the results that come up. So Ms. Rain from the Robert Wood Johnson Foundation says that patients need to be able to navigate the healthcare system, which raises the question, how in the world does anybody do that? These patients all tried their hardest and failed. And Dr. Grumman has this to say about being drop-kicked into a foreign country and being a tourist. This is absolutely true. Although being a tourist can imply a pleasant experience in the healthcare system, that is 99% of the time not the case. So how does a patient navigate the healthcare system? As patients, we think that our doctors and the staff in their offices are watching out for us. But as these three cases illustrate, that simply isn't the case. So do you have to have connections? Does that help you in some way? Well, the last patient had a ton of connections. His sister, his sister-in-law, his cousin, his brother-in-law is a radiologist, tons of advice and tons of insider help. And his wife works at the medical school, and I'm his wife. And no matter what we did, we could not navigate the healthcare system, and we could not help him get what he needed. The cases I've told you about today happened across multiple practices here in Springfield, and in some cases outside of Springfield. I have to believe that some practices are exemplary and excellent at implementing systems that patients can navigate, but clearly there are many that are not. And just to clarify, there were no residents, medical students, or anything involved in any of these cases. They were all long-time, highly experienced, highly recommended practitioners. And I tell everyone every day that if a resident had been involved in at least my husband's case, I believe that they would have stayed on top of it and these things wouldn't have happened. So back to the question at the beginning. Again, a rhetorical question. But my answer would be that there absolutely are improvements that can be made on the front end of the healthcare system. And making those improvements has to be a very high priority. So I want you to think about these questions in your current practice, future practice, whatever. How are you going to make sure that your patients fare well in whatever system you're practicing in? Do you know the answers for these questions for your current clinical areas? And Dr. Sanfie did a great job talking about, the areas in the hospital for communication breakdowns. But the people in the last two cases were never hospitalized. So there was no checklist, no handoff, no medical error form anywhere to fill out that would have maybe prevented these things from happening. And I want to end with a little story here too. How many people, does anyone in here not have a cell phone? So everybody has a cell phone. Okay, so you've all dealt with the cell phone providers, and I know they're frustrating and aggravating and they're time consuming, but I just want to go through this with you a little bit. After my husband died, there were lots and lots of things to deal with, as you can imagine. One of them was canceling his cell phone service, and I dreaded it. I just dreaded having to make that call and do that. I put it off as long as possible, not because I dreaded it so much, but because his friends and family from all over the world and my children still called his cell phone regularly just to hear him say, "Leave me a message." And they would pour their hearts out in his voicemail. But the phone had to go. The money, couldn't afford it, so the phone had to go. So when I called the cell phone service provider, they expressed their sympathy. They canceled the service for his phone. They reviewed the services I was paying for to see if they could make the bill cheaper. And it took maybe a half hour, during which time they were very accommodating and very helpful. And I was so struck by that. I didn't have to make an appointment and sit anxiously by my phone and wait for weeks or months for someone to call me back. They just did it. They acted like helping me with that stupid cell phone was a life or death situation. Only it wasn't. What you guys do is life and death. But patients wait every single day for doctors and their offices to get back to them. I understand perfectly well that medicine is much more complex than a cell phone system. But I also feel very strongly that our current healthcare system, as far as communication goes, is seriously, actually fatally flawed. So to take from Dr. Sanfi's presentation, what questions do you have for Dr. Sanfi or I? Any comments, questions? Looks like we have lost Decatur. No, maybe they're still on. Anyone in Decatur have any questions? We did file a complaint with the hospital, and I don't know what was done. They just assured us that it would be corrected. In meeting with all the doctors later, I was told that everyone looked at the scan and said, there's nothing I can do about that. I'm not even going to come see this patient in the ER. So there were no consults that afternoon or evening because no one would come to the ER. And so the ER really had no choice but to discharge my husband. So I really don't know what the hospital has done to make sure that doesn't happen again. Here at SIU, Dr. Dorsey had implemented some studies as far as wait times for patients to get appointments and wait times for phone calls to be returned. But I don't know the results of those. And I can tell you that as of today, we still hear all the time of patients. One patient just called the other night and said, I've been waiting 5 days to get my prescription refilled. I'm out of medicine. What do I have to do to get a call back from you people? So I don't know.
I think, Debbie, I don't know about the timing of what happened, why and when, but certainly I know the faculty often get what they call secret shoppers, so people who will phone to try and get an appointment. And one of the measures that's used for our faculty is how long does it take to get an appointment for a new patient? How long does it take to get a follow-up appointment? And they also measure the time taken for the call center to refer, how accurately they refer. So it's a work in progress because, as Debbie has said, there's still a lot of dissatisfaction out there with callback time, appointment time. We're working on it.
Yeah, so I would love to say that it's fixed, but I don't think it is right yet. And it's all practices. My daughter